I have to cut the name of the talk because it was too long for YouTube. Okay, we are online, and I will pass again to you the command, okay?
Perfect.
Okay. Mark. Okay, I give you. Give me 2 seconds for your presentation, please. Maybe we have 2 minutes and people is coming.
Yeah, no problem.
To begin. Okay. Did you
okay if I it's okay,
did you
okay if I
came to South America sometime?
You know, I used to go to Chile to go fly fishing.
Chile, no.
Down in Patagonia and Argentina. I had a
Great country.
it's beautiful. Yeah, I had an opportunity to fish down there in southern Chile every year for about 8 years through a
Wow.
lodge that I had a little tiny ownership in a little lodge down there. So it was.
So you speak Spanish?
No, I don't.
No.
No, I don't. I speak a little French, but not enough.
Just to ask for coffee.
I visited PJ down in Santiago for a week as well. So yeah.
Okay, you can put your
Can you guys see this?
Okay.
Can you see my slides?
Right.
Okay.
Great. Okay. Let's go to start. Okay, good morning. I will do my presentation in English, please, for respect to our guests. I have to say thank you very much to Dr. Makin because he was in the first time I invited him to be with us, he told me yes, and this is amazing. Dr. Makin is the surgeon-in-chief, vice president of the Riley Surgical Service, Riley Hospital for Children, professor of urology, Department of Urology, Indiana University, trustee president-elect. Dear Mark, thank you for being with us. The command is on you. Okay, thank you.
All right. Well, thank you so much for the kind invitation to join you. I miss the years when we could all be together in the same place and share surgery together, and I could come down and watch how your program works. So hopefully someday we can do that. Today, what I'm going to focus my discussion on is really my experience at Riley. And if you're not aware of Riley, we've been kind of one of the busy surgical departments in the United States regarding bladder reconstruction. And so I'm going to talk a little bit about the questions we asked, the results that we achieved, and then what we've really concentrated on the last 5 or 10 years as I became chief to understand the long-term outcomes of these kids. So this sometimes generates more questions than it does answers, but I think it's important to ask these questions. So we're going to look at, this is my personal view. I started pediatric urology journey in 1992. And this is really my view on why large databases are really important and why looking at your own results are critically important to understand what the long-term benefits and risks are to the patients. And then also just making really good decisions in kids who we don't know what's going to happen as they become young adults. And I think both hypospadias and major bladder reconstruction share these same needs. I like to show fishing pictures because I'm a big fisherman. I consider this talk my youth versus truth. And this is when we're, I think, early in our careers, we want to write a bunch of papers. We want to go and see things. And then as we maybe get a little bit wiser during our careers, we want to ask really hard questions. So Riley Hospital for Children, we just celebrated our 100th year. I was chief for about 10 years in the 2010 to 2020 era. This is Mike Mitchell, Rick Rink. I took over for Rick back in 2010, and our current chief is Rosalie Masiri. And we really built a foundation of really major reconstruction. And it's why I came to IU. I made a career decision to leave Georgetown and to go, mostly because of these two gentlemen that have the circle. That's Tony Casal and Rick Rink. They were doing really innovative things. And I think as a young surgeon, being around people like that was critical for me, not only to become a better surgeon, but also to learn how to ask questions. And I look back, this is one of the first articles I wrote when I got to Riley. And we just finished our 100th Mitrofanov procedure. And I thought, what a chance to go write about this. And I look back at this paper, and it was a terrible paper. Even though it was the first kind of series that had 100 Mitrofanov channels, it was constructed really poorly. And so learning how to do hypothesis-driven, ask the right questions in the right patient population. If you look at this, it was variable procedures with variable follow-up over a long period of time. And that inherently has problems and leads you to conclusions that are incorrect. And I remember I presented this at the AAP meeting, which used to be the biggest international meeting in North America. And Dave Bloom, who was a professor in chief up at University of Michigan Children's Hospital, came up to me and he put his hand on my elbow and he said, "Mark, this is really good, but I want you to show me 100 patients with at least 10 years of a continuous follow-up." And he was talking about anything we do. And he looked me right in the eye and he said, "If you can do that, you'll actually have made a real statement that makes an impact on how we're going to take care of these kids." That was one of the first things that actually made me change the direction. Instead of just writing big series, it was asking the hard questions and then looking at the database with long enough follow-up to try to answer these. Now, these patients are really tough, I think. These are the types of patients that may need bladder reconstructed at some point. I honestly think these are the toughest patients we deal with because they're social problems, they're psychological problems, they're anatomical problems. And we're really at the end of the day, we're really left with what we started with a lot of times as far as our success. And getting these kids to urinate, I think, is almost impossible sometimes volitionally and on their own. So I like to quote people that are wise sages. And I think Bernie Churchill, when he was up in Toronto, he kind of threw down the gauntlet that anytime we're going to reconstruct these kids, the number one thing, we're going to preserve life, we're going to maintain renal function, and then we're going to try to get urinary incontinence and try to maximize sexual function. We spend a lot of time talking about complications, but if we remember this pyramid is where I like to look at it, and that the bottom line is they're not going to be kids forever. And so also adding to this is transition to independent care, where they're going to care for themselves, and then asking them about their quality of life becomes critically important to understand what type of surgery, if any, is going to be important for them. Now, there's no question this is for the younger staff, the younger in training folks in the audience. The history of spina bifida has been one of cure of major complications, which were including renal failure, which was inevitable because of high bladder pressure, reflux, infections, and the eventual damage to the kidney that occurs. Ideally, we don't see this anymore, but we still do, where we're seeing progressive preventable renal injury. So there's a whole bunch of techniques. This is a whole day's worth of discussions and lectures from experts in each one of these options for how we manage the bladder. I'm really going to concentrate on surgical reconstruction of the bladder for this discussion today. So again, ask the question, at what point does what you're trying to address matter? And this is something I borrowed from Dan Wood and Elizabeth Yerkes, who was one of our prior fellows. Each of these important factors to look at matters, but it matters in a different way during this child's kind of progress through life. And so the questions and the answers may need to be different. The other dramatic thing that happened to me is I had a metastatic germ cell tumor when I turned 50. That guy right to my left there is Larry Einhorn. Larry Einhorn cured testis cancer. He's 50 years ago developed platinum-based chemotherapy. And when I talked to him about my disease and his career, what interested me most was how he actually understood that he did something dramatic, but a whole rest of his time, he was trying to minimize the side effects and the complications of the chemotherapy to get better quality of life. In this book I'm showing, Atul Gawande, he is a general surgeon out of Boston, became famous writing about questions about surgery and training. He wrote a book about being mortal. This is about his dad who died of prostate cancer, who interestingly was a urologist in the state of Ohio, and what things matter. And I think it's important to read this to understand how we ask different questions during different times before we introduce major surgical reconstruction. So the difficulty when you look at any data or listen to any talk is that when we look at reconstruction, there's really three factors that influence the outcome from this. There's the bladder outlet, which can be poor and they can be incontinent from that. It can be the bladder itself, which can be either small capacity or high pressure, both of which are bad. And then we have to look at how we're going to empty the bladder if we have to address the outlet. And that's where the Mitrofanoff. We're going to talk a very tiny bit about Mitrofanoff, focus primarily on the bladder reconstruction. So this is in the mid-2000s. Peter Metcalf was our fellow at that time. And this is in the era where you had to go back and actually pull charts that were 6 inches deep and actually find the data to look at this. He went back and found kind of the outcomes and the surgical procedures done on 500 straight augments. So at that point, that was the largest series in the world. That still may be the largest kind of cumulative experience published. It focused really on complications, and that was the problem, is that it focused on what was the cost of surgery, and it actually made people look at this quite differently, I think. It was very honest. We were trying to say, we've done a lot of these. We think technically we can do this operation, but here's the side effects that you have to talk to the families about. So you can see about 2/3 of the patients did very well in this series. They did not require a lot of secondary surgery, but 1/3 required many operations. And it wasn't a far reach to understand that if they required additional surgery within a 5 to 20-year follow-up, that if they were going to live another 5 or 10 years beyond that point, they might require additional surgery. And so the follow-up is really important. So the bad thing about this is it kind of threw this kind of fiery kind of opinion about augmentation on what I'd say. This is actually a map of Colorado where they were having their fires, and they had freezing rain, fire, and snow all at the same time. But honestly, it's how you approach these problems, not what you're facing, that makes a difference. So what I felt we had to do at that point was to actually go back and prove what the value long-term of an augmentation was. And so first thing we asked was, did it change the survival? And so what we did, we had of the spina bifida population, of those 500 augments, just about 370 of them were patients with spina bifida. And we knew what the outcome prior to bladder management. So we broke this down into data from 1952 to 69, that's before intermittent cath. From 70 to 86, that was the intermittent cath era. And then compared that to patients that had an augment during that same time period of bladder intervention, so 72 to 2009. And what we found that is up to about age 20, the very top line, 28 patients died out of this 370 or so about 7 to 8%. It wasn't that far off the age expected survival of the normal able-bodied US population. So we actually did change their outcome. They didn't have early mortality. They didn't have urinary tract mortality. So that was a good thing. And when we looked at why they died, the most common cause of death was neurologic. So it was mostly VP shunt infections, pulmonary disease. There was still some urologic cause of mortality, but it came down to only about 2.6%, not the 60%, 70% that we'd seen prior to bladder intervention. So were we doing good? The answer is yes. This is also borne out this is a French study. This is a longitudinal study, operated and non-operated. They saw a higher incidence of urologic disorders in these patients that caused death, including urinary infection, some renal failure, bladder cancer. But really, again, pulmonary death was the leading cause outside of urologic causes. And this is another group. This is a 47-year retrospective study, multiple institutions. I circled the blues there. Those are all my prior fellows. So we inspired them to actually be really thoughtful about how they looked at this problem. Doug Hoosman, I circled in the middle. He was my mentor at Mayo Clinic when I trained in pediatric urology. He was the grandfather of all this. But when we looked at shunted versus unshunted, neurologic causes still compromised or created the highest risk of death in the shunted, and that has to do with VP shunt infections. If they were not shunted, they had a fairly low risk of neurologic death. And the second most common cause was clearly pulmonary, or even the most common cause in the non-shunted patients. If we looked at survival beyond a year, so take out the kids that had tragic death early on, if they were shunted, neurologic was clearly the highest. If they were unshunted, pulmonary was the highest. And then if you looked at augmented, very similar to ours, very low incidence of urologic death. It's a little higher than we reported, but these were not all patients that were augmented at the same time frame. But if they were not augmented, their urologic cause of death was actually a little bit lower. These patients did better. They had better bladders, which makes sense. So again, the question that we wanted to really ask at that point, after looking at this, determining in our mind that we actually were doing good for these patients that had bad bladders, we had to then ask, what are we doing for the patient's quality of life? And what we saw when we looked at the literature was there was really no way to assess that. And so Konrad Szymanski was our fellow. He was a MPH from Harvard trained, as well as a pediatric urologist. And we decided that we were going to spend money and create surveys that were just directly to spina bifida patients, which was absent in the literature. So we created multiple quality of life assessments for children, adolescents, and adults. We translated this into about 6 or 7 different languages. We studied it internationally. And sure enough, the questions followed what we thought they would be, but actually had some different kind of tweaks to the answers of the patients. And we compared this to normal controls as well. So the first question is, what do they care about being wet or not? Because a lot of what we were doing was reconstruction for continence. So you had to ask the question, did that matter to the patient as they got older? So interestingly, if you look at the urologic kind of literature, it's usually 3-hour intervals, or do you wear a pad? It really came down to how wet they were. So if they were really wet, their quality of life score was really poor. If they had no incontinence, they were up in the kind of 80+% health-related quality of life. This is really close to able-bodied people without spina bifida. And then it kind of came down like this based on how wet they were, which makes a little bit more sense if you just kind of think about it. The even more surprising thing was fecal incontinence was an all or nothing kind of, and if you think deeply about it, urinary incontinence, we can hide it really well. We've got really good pads, diapers. Those kids can hide that during their childhood pretty well, but boy, the minute they have fecal incontinence, their quality of life is really quite poor. Then we asked the question, when does it matter? So first, it mattered to the patient. It mattered how wet they were. So the question is, which is important for timing of reconstruction, when does each of these types of incontinence matter? And this is what surprised me most. If you looked at kids with spina bifida, they actually didn't have a really significant change in their quality of life score until they were teenagers. And we'd always adopted the theory that we were going to make these kids dry by the time they went to school. So by 7 or 8, these kids would line up in our clinic, and we had taught everybody in the Spina Bifida Association in Indiana that we're going to make them dry at 7 or 8. The big problem here is the kids don't care. So they're not going to participate as much in their surgery, their recovery, or even in catheterization at that age. And so we were a little bit early in our timing for reconstruction in kind of that 2000 to 2010 era. Since fecal incontinence mattered all or nothing, it actually mattered early to these kids. So developing a really aggressive bowel program, maybe considering doing an ACE or some type of a percutaneous ACE to help them avoid fecal incontinence. It was really important, and it mattered a lot the minute they walked into school because they were around their peer group at that point. So that answered that question about timing of surgery. So the next question, obviously, was what happens when these kids grow up? And this is the same patient. This is back in 2003. I did a bladder neck repair and a metrophonal, not so a girl. And this is her at about 25. And we have a transitional clinic. We take care of these kids into adult life, 40s and 50s. Twice a month, we have a big clinic, 30 or 40 people come in that are adult myelomeningocele. And it was driven by the fact that somebody had to take care of these kids that we'd done reconstruction on. So we started asking questions. If they lived into their adult life and they were dry, were they sexually active at all? And what was the implication of that with their continence or absence of continence, both urinary and stool incontinence? And so we started asking, are they sexually active? You know, a lot of these kids have major nerve issues, but they found ways to be active from a sexual standpoint. So if you ask them, 90% were active sexually in some fashion. Where they were finding their erogenous zones was somewhat related to, did they have a VP shunt? Did they have good kind of sensory neurologic sensation down in the genital region? But all of them found ways to achieve sexual satisfaction. So next question would be, if they're sexually active, are they bothered by being incontinent? And this was Josh Roth was our fellow. He did 2 fellowships in adult reconstruction. And he went back and looked at it. What was the impact of urinary and fecal incontinence? And it was again related to how much incontinence did they have. If they had a lot of incontinence, during sex, they were bothered a lot by it. If they had very little, it wasn't much bothersome. So almost the same line of quality of life, and related to how incontinent of urine they were. So if they're always incontinent, they were very bothered. If they're almost never incontinent, they weren't much bothered by it. And again, if they were fecally incontinent during sex, it bothered them no matter if it was all infrequently or every single time they had intercourse. So then the last question we asked was about regret. Obviously we've looked at that with hypospadias in adults. Do you regret having the reconstruction for your penis? Same questions apply to kids that undergo major reconstruction. The stakes are, I think, a lot higher because the risk and complications of the surgery are much higher, that don't go away ever. So we asked these patients, and this was a cohort of about 100 patients that were back in our adult spina bifida clinic. Most of them had both augmentation and emetrophenol. We use all these different decisional regret scales to understand whether or not they would do the surgery again. And so very interesting, and this was unrelated to whether they were continent or not. 87% said they'd do the operation again. They had very little or very, very mild decisional regret. And I would say that's probably as good or better than hypospadia surgery, a lot of the other operations we do. And we were surprised that that was that high. We thought there was going to be a lot more decisional regret because of the need for continuous follow-up, the maintenance of, emptying mucus and things like that. It's a lot of work for these patients, but they were happy enough with their outcomes that they had very little decisional regret. So I think that whole kind of 10 years of looking at quality of life led us to conclusions that actually reconstruction and continence does matter in these kids. The timing was a little bit different between bowel and urinary continence achievement as far as how the patient would look at it. But then we had to actually address the fact that if the kids were going to move towards continent procedures, the ones that chose that, the timing and the type of operation mattered. Now, during that period I talked about earlier, after we published that 2005 article where it said there's a very high incidence of complications, 34% are going to have some kind of problem. And a portion of those are life-threatening problems, which we'll talk about. Bladder rupture, cancer in the bladder. Many groups across at least North America decided we're just going to do bladder outlet procedures. We're going to give them a way to empty their bladder, and we're not going to augment them, no matter what the bladder looked like. I think we've kind of already proven that's dangerous in the history of how poorly the patients did before urologic intervention, catheterization, etc. Here's a perfect example. This is my patient. This is a child that I thought was a great candidate. You can see he's got a poor outlet resistance. His bladder looks pretty smooth walled. His kidneys look pretty normal, just grade 1 hydronephrosis. His urodynamics looked relatively safe. He was a 7-year-old, thin, didn't weigh much. So a bladder capacity of 150 to 200 cc's was actually appropriate for his catheterization intervals. So I did a classic kind of Churchill bladder neck tightening and a sling. I did a Mitrofanoff procedure on him. And this is what happened 6 months later. So you can see his functional bladder capacity is now reduced to less than 100 cc's, where he reaches really high pressure. He's got very poor compliance at this point. And as you can imagine, he's developed hydronephrosis, bilateral high-grade reflux, and a very trabecular-ended bladder. A good outcome with his bladder neck. He's dry now, but at what cost? And so this patient ended up getting an augmentation fairly quickly, within about 6 to 9 months after his reconstructive procedure. So if you go to the literature, even our own literature says these patients are dangerous to do just an outlet. They have to be followed very carefully. when we looked at our first kind of using the AUS in this population, about 25 to 30% needed a late augmentation. If we looked at our young Ds or crop or sling procedures, about 45% of about 125 patients. And if you looked at the biggest series, where the biggest proponents, which is down in Dallas and in Texas, in the United States, where they'd done about 100 patients, they ended up having fairly significant, CKD in about 20%, hydronephrosis, reflux. They finally published, this is, I think, just online now, these 120 patients they followed over time. And it's as you'd expect. If the patients had really good compliance, so if their compliance was good, they had large bladders with no pressure, these patients needed very little additional surgery. And then they were graduated, that you could triage them into, compliance of 15 to 30. That's this line, needing additional surgery, including augmentation primarily. And this is the patients with really poor compliance, less than 15, that just had bladder outlet procedures. These patients had, 50 to 75% need for additional surgery by 10 years. And even more importantly, a large number of these, this is the DSA abnormality based on these two things. And it follows exactly what you'd expect. If they needed additional surgery, or if they had major problems, they ended up 25 to 50% had DMSA scarring that they didn't start with. It was fairly quick, 5 to 10 years after surgery. So again, the kind of lesson learned from this is that this is not the wrong thing to do. It's just you have to choose these patients, I think, really carefully, and you have to follow them even closer than you did before. So, we still believe that the augmentation is a gold standard. The number of patients we augment has decreased significantly. It's for the patients like this you see in the middle. This bladder is just not going to respond to medical management. They've got the compliance changes primarily due to a change in the muscle and a change in the interstitial space, the collagen content of that bladder. You can see how it just looks really abnormal, thick-walled. At this stage, that's probably a terminal event in the bladder. These are the patients that we still consider for augmentation. We prefer ilium. It's just easier for us to use. Remember, it needs to be detubularized and reconfigured to get you the largest volume, but also lower the pressure based on how much you take. So back to where we started with, talking about this Indy 500. This is now 15 years later almost, where we had another 15 years of follow-up. The other problem with this study, it was a mixed bag of patients. The diagnosis was pretty varied, and we wanted to focus at this point on the spina bifida patients who we knew had the highest risk. Many times the other patients, whether it be extrophy, valves, absent bladder, those patients were frequently being operated on for continence, whereas the spina bifida patients, both continence and bladder protection. So we wanted to look at them specifically. So we actually honed down the study and only looked at a portion. At this point, we had about 900 patients in the database, but we looked at only the patients that were spina bifida born after 1972. So it took us from about 800 patients down to 400 patients. And this is the average age of surgery. And then the follow-up was beyond 10 years. But again, we had mostly ileal augments. Most of them had some type of urinary channel. And we did MACE procedures simultaneously in a large number, about 2/3 of these patients. So what was the mean follow-up of about 11 years? 44% had additional surgery, and most of them had more than one operation. And of the patients that had multiple operations, 1/3 of those were the same operation, whether it would be for stones or secondary rupture that happened again. Those were the two most common things that required multiple operations. So you can see the surgeries that were done on these patients. Again, the majority were for bladder stones. Next most common was for bladder perforation. We had 60 perforations in these 400 patients, which is a lot. That's much higher than we had published earlier. So this risk goes up, and this is the timetable. If you look at them in the first 5 or 10 years, you get into that 30 or 40% range. But if you look out here, the patients that get out to 20 years, the numbers are smaller, but the number of patients requiring additional surgery exceeds half. And the number needing additional surgeries, 2 or more, is about 20% or so. So fairly significant risk to these patients. Now, some of these patients are just going to fail. And some of this has to do with that as these patients get older, especially the patients with VP shunts, they tend to have trouble with their VP shunts, a small percentage of them. Each time they have a shunt problem, they tend to drop IQ points. And the biggest outcome of that is they forget to do things. They forget to catheterize. They forget to irrigate their bladder. And so they become much higher risk patients, both for stones, for infections, and for rupture. We went back and actually did diversions on about 2 or 3% of these patients because of either recurrent perforation, incontinence that we just could not get, or upper tract changes where everything was failing, either because of the patient not catheterizing or the operation itself was failing. Temporary, the ileal chimney, I think, is a good answer. I think most of the data, this comes out of Doug Hoosman's long-term follow-up. As an isolated long-term procedure, suprapubic tubes actually beat the ileal chimney for least number of complications, and it was actually better than an ileal conduit. We use this for a temporary diversion. So if we've got a young patient that's not ready for surgery yet, needs something done, a vesicostomy is not going to work because we want to put a bag on them. It's the 6 to 10-year-old child. We'll use this because it gives you a budded stoma and you can empty it. We have them irrigated to avoid stones. We try to avoid ileal conduits unless it's the adult patient that just has no other options, but we still will use that operation occasionally. Now, to look at the highest risk of operation of stones, how you manage it's really dependent on what the stone looks like, and they come in all shapes and sizes. So a big stone like this, this was as big as a hand. It's probably open operation is probably going to be the best. You can do that percutaneously and dust that stone. The risk of recurrence is much higher with the larger stone. The small stones like this, great percutaneous or even transurethral type extraction. And a small stone like this that's under 2.5 centimeters, we've tended to do those all percutaneously to avoid open operations in these kids. And so the question at that point, and it goes back about 10, 15 years, is if you fracture the stone, do you have a higher risk of recurrence? And so we looked at that, and interestingly, it broke down almost exactly evenly. This was about 100 patients, at-risk patients here, but this is about 100 patients that had stone intervention, whether we endoscopically, percutaneously, or open extraction, the recurrence was identical. It was about 50%, irrespective of how we actually manage the stone. So I think you do it based on what's going to be best for the individual patients. If you look at stone risk, the channels actually increase the risk because the channels tend to siphon the urine out of the augmented bladder, I think. It's hard to get down to the dependent base, whereas if they had no catheterizable channel and were emptying per urethra, they have almost half the incidence of stones in those patients. And so if the urethra is open, we'll frequently, if the patient starts getting stones, have them catheterized per urethra. This is a technique. We published a couple papers. A lot of other people have too. I personally like to have through and through drainage. So this is a catheter in the channel so we can keep the pressure low. I use usually the site of the old suprapubic tube to access the bladder percutaneously and just put a 12 French trocar in the nephroscope. And then you can either extract the medium-sized stones or just break them into large fragments to not have to dust the stones. We'll usually leave a Foley catheter in this and this catheter in and have them through and through irrigate. And that may be why we have a slightly lower risk in fractured stones of recurrence, because we're going to have that family really aggressively irrigate for about a week after surgery. And ideally, that would free up all the fragments out of the bladder and prevent recurrence from the small nituses. If you look at just in general, this is Doug Hoosman, my mentor's data. He looked at what you had to do to prevent stone. And we historically just told the families we'd like them to irrigate with 30 to 60 cc once a day, kind of, in and out a couple of times. That actually didn't reduce the risk of stones in Hoosman's series. He looked at the difference between 60, 120, and 240 mLs. This is a big ass. This is 4 of those big syringes in and out. That's the only thing that actually lowered the risk over time, this 10-year period of follow-up of stone. So everybody else had about a 50% stone recurrence. Once they started irrigating aggressively, they had to lavage the bladder to actually lower that. And so this is what we've gone to. And so the question is, do they actually do it? So we actually went back, and all these adult patients that were coming back, we actually sampled them to find out, well, what do you do at home without being threatening at all? And 0% were adherent, where they were doing it, more than 6 times a week with 120 mLs was what we asked them to do. None of them did it. Matter of fact, most of them were doing less than 2 times a week. And so not really enough to lower any incidents, and 10% did no irrigation at all. So part of the problem is that we've got a patient population that's not going to adhere to the things we know are going to lower their risk. The other thing that came out interesting from this that we saw, and then we actually studied independently, is that we've always quoted like a 1 to 3% risk of kidney stones after an augmentation. And if you follow these patients long enough, meaning over 10 years, they actually have a much, much higher incidence of kidney stones. And we don't know why. Most of these patients didn't have reflux, which is a known factor because they're refluxing mucus into the upper tracts. That increases their risk of stone. Most of these we think probably are some type of metabolic problem. These patients are less mobile. They get bone demineralization. They all have some minor hyperchloremic metabolic acidosis. We've not been able to go back and study this quite yet to see, is there something we need to do, like treat them for stone disease medically, to see if we can lower this incidence. But this is a pretty high incidence, 18% at 20 years. This is literally 3 or 4 times what we had published previously. And I think it, again, has to do with how long these patients survive today, and their risk factors are different. And even though we haven't treated minor metabolic acidosis, this may be a factor for these patients. The need to re-augment, we've looked at this in kind of the modern versus the old series. And again, the old series, they didn't detubularize and reconfigure the augment. Most of those patients needed to be re-augmented. There were a large percentage, 15% at 10 years, and it actually went up even higher because of the capacity being too small. They were either incontinent or they're getting contractions. So small number, about 5% if we did the modern type surgery. We're going to use ilium, detubularize, and reconfigure it. And we looked at this together with our friends over at Cincinnati with about 300 patients in what we considered the modern era, where everybody had ilium, everybody had detubularized and reconfigured. And it was a risk of about 1% in that series, which we think is probably accurate, even though the series would suggest higher. The other thing that we don't really talk to the patients about is a need for additional surgery for bowel obstructions. Most of these we've tried to treat conservatively, but the laparotomy for bowel obstruction, it was about 5% at 10-year risk. And mostly it was a small bowel obstruction. And some of these patients were where it was wrapped around pedicles, because remember, 75 to 80% of these had either a MACE or a Mitrofanov or both. So there were points of internal herniation and obstruction that was in addition to the augmentation itself. In addition to the hyperchloremic metabolic acidosis, which on exams is always the right answer, what's their most common metabolic consequence? It's going to be a acidosis related to how these patients manage the ammonium chloride inside the augment. They reabsorb chloride and then passively follows the acid. But the other thing that happens, and this is irrespective of where you take the bowel segment, is that they're a much higher risk of B12 deficiency. In this series, we just looked randomly at them, and about 20% had what we considered low B12 within 7 years. And when we timed it, it happened as you'd expect, because you've got enough body reserves of B12 to last about 7 years. So it was about 7 years when we saw the patients fall off on their levels. And so we would recommend actually studying these patients early on. Why? It has neurologic implications, and these are patients that are already neurologically compromised. So you want to treat this pretty aggressively. Now, fortunately, you can treat them with oral B12. These are before and after. The patients that were low or medium low, all of them got up into normal levels, 300 to 1,000 just from oral replacement daily. But again, the problem is their compliance, not the bladder compliance, the patient compliance to therapy. It was really low. So of the 36 patients that had documented normal levels, 25 of those patients dropped to abnormal with follow-up. And so those patients needed intramuscular B12. So you have to keep following even after demonstrating that you've recovered their B12 levels. Now, the big worries that we heard about and that changed people's kind of opinion about augmentation are the two lethal potential complications, perforation and malignancy. Interestingly, in this study of 400 patients with only spina bifida that were done after 1972, we had no malignancy. Now, it was difficult for me to actually have this in the paper because we had 4 patients die of malignancies. And the problem with the malignancy is it usually presents high grade and late and high stage. And so almost all of them die because by the time they get to you and you can't screen them off enough to pick it up at an early stage, and it happens usually right at the anastomosis, so it's through the bladder almost immediately. We had 4 patients die with transitional cell carcinoma, not adenocarcinoma. So it felt funny to write this, but if you look at actually the risk, it's no greater than the patient that just does intermittent cap. You can see that in the French study. And this is Doug Hoosman of Tai Higuchi, who's a transitional guy in Colorado now. They looked at 3 different disease types, about 150 patients with long-term follow-up. This is 10 to 20-year follow-up. So if you had an augmentation, you had about a 3% risk of getting 2 to 3% risk of getting cancer. If you had no augmentation, just emptied your bladder with catheterization, you had almost the same risk. And this was surprising because we focus so much on the cancer in the augment patient and have forgotten a little bit about this in the process. Now, interestingly, if you had extrophy, your incidence of cancer was almost triple if you had an augmentation, up to 8%. And the highest group, not surprising, was the valve patients, because most of these patients were getting augments in preparation for a kidney transplant. So not only did they have a bladder problem, they were also immune suppressed, and they were also getting viral cystitis, which increased dramatically, 12%. This is the highest group. I think this has moved most of us away from augmenting these patients unless there's just no other option to manage their bladder. So bladder rupture, the best test for this, I think, clearly in the literature and in our own study, is a CT cystogram. And all you're looking for is symptoms and increased fluid. You can see it on the CT scan. We looked at 45 ruptures that all had CT scans. And sometimes it's hard to see the contrast because there's so much urine in the abdomen, it's dilutional. You can barely see it here where you've got a little contrast in the posterior aspect. But this patient had fluid. So if they had increased fluid from baseline and they had any symptoms of abdominal pain, almost 100% of those patients had a rupture. The biggest risk factors in Doug Hoosman's series, if the patient either had poor compliance and catheterization, or if they had some type of abuse, either narcotics or recreational drugs, they had a much higher risk of perforating the bladder. So if you look at 10 and 20-year risk, it's the same problem in the patients, and you have an increased risk. And those that rupture tend to have recurrent ruptures. So this is where bladder neck surgery also causes increased problems because they have no way to leak if their bladder reaches capacity. So if they've had no bladder neck or a sling, they were actually protected because they leaked before they ruptured. So if we do a tight bladder neck outlet procedure to get them dry, their risk of rupture is the highest. So again, we always think we're doing better because we're changing how we're doing things. So we looked at the current population, meaning 2000 to 2020, to see, were we any better? Were we better about selecting patients? Were we better about educating patients? And the bottom line is the answer is no. Every single risk was identical or higher in this patient group. So we actually aren't any better at selecting patients or teaching them what to do and not do if they undergo a bladder augmentation. And it has to do with the patient population. So the other thing we've seen is these patients, as they've grown up with augmentations, the other reason you need to be involved is that the females are fertile. The women are fertile. So we had a 20-some pregnancies. And what we started seeing is that a lot of these patients would come to C-section. And during their pregnancy, they actually had a pretty high risk of having hydronephrosis, over half. A lot of them required nephrostomy tubes if they had hydronephrosis. And they also had difficulty catheterizing. And then in addition, a lot of them ended up with C-sections, 7 out of the 15 in this group. And half the patients that ended up with C-sections actually had to have reconstruction or closure of a cystotomy. There was one that actually had a ureteral vaginal fistula when we weren't there. So we've actually decided we're going to be there for all the elective and the emergent C-sections in these patients if they require C-section. And we want to do it on a planned basis to try to minimize these risks, which is fairly significant complication. And again, these moms are delivering and they're having to manage their bladders afterward. So here's what I would tell you today. Here's the best case scenario. This is not, half or more of the patients are going to do well. It's actually less than half the patients are never going to require another operation. Bladder stones, again, the highest, but perforations now we think in the 9% range. Secondary augmentation, 1 to 4%. Bowel obstruction, that 10 years, about 5%. But again, bladder stones is the big need for additional surgery, and it's the big need for second and third operations in these patients. So how do you follow them once you do it? How do you minimize complications? So we see these patients back at a minimum on a yearly basis. We'll get an ultrasound. We'll intermix KUB. Cystoscopy is not proven to be effective. The subset where it might be are the recurrent stone formers, because you want to consider doing endoscopy and taking these small stones out in the office rather than letting them get big, where you may have to consider doing either an open operation or a percutaneous procedure. Those that have recurrent UTIs, they need follow-up sooner than yearly, because this is usually going to be a stone or some type of technique problem with CIC. We want them back in the clinic more frequently, every 6 months. And then we do a metabolic evaluation yearly on these patients. So these are the common things we get. There's been some suggestion that we get DEXA scans. This, again, is related to their effect of the long-term metabolic acidosis, especially in females, and osteopenia and osteoporosis. Now, cancer surveillance, we still don't know what's best for this. We don't have any urine markers. The studies on cytology, yearly cystoscopy haven't helped. Probably the low-risk patient doesn't need anything more than the general yearly follow-up. If you have a high-risk group, that patient that may be in the valve augmentation, recurrent infections, recurrent stones, we may want to consider cystoscopy in that patient group. I want to spend just about 5 or 6 minutes on Metrophenops. It's another area I've had a lot of interest in over the last 30 years, and something that we've learned a few things that are tips and tricks, I think, that are helpful. Here's Paul Metrophenov. It was interesting. He practiced in a fairly small village, really, in France, but he came up with a brilliant idea that he could use the appendix to tunnel into the bladder using a classic ureteral reimplant technique and give the patient a way to empty. It really revolutionized, I think, our ability to get the kids dry, because now we weren't dependent on the urethra that had to be reconstructed for dryness, but wide enough to allow catheterization. So the Metrophenov principle is fairly simple. The appendix is a great channel. It's there in most patients. It's supple. It's a sturdy tube. It's usually long enough to create the 2.5 centimeter intravesical tunnel. And then you can bring it up to the skin. It has its own blood supply. So perfect channel, fairly simple operation, since we are so used to doing things intravesically. When it's just the channel only, I love putting it in the umbilicus because it's easy to hide. There are other alternatives. This is the appendix. Here's the Monty channel, which was developed in South America. It's just taking a small segment of ileum or large bowel and splitting it right about 90 degrees in the midline. It gives you an equivalent channel on either side. You can cut it offset to get a longer intravesical and a shorter extravesical tunnel, but it has nice blood supply that comes in right at the middle. So it avoids this complication of the long meso appendix here. And then this is a Casal Monty. And the only time we're using this today is that if you have a patient that has a lot of abdominal girth, you need sometimes more than what you get with a standard Monty to get up to the skin. So this gives you that extra distance. If you look at complications, it's going to be either incontinence or stomal stenosis. That's the majority of them. All the other complications are inside the abdomen, and they're much higher stakes complications. I personally think this is right around 2%. I think we can avoid the stomal stenosis with technique of creating the stoma, but also leaving something across it. What we haven't hesitated to do is we used to take them out at 3 weeks, the catheters post-op. We tend to leave them in 3 to 4 weeks, and we tend to leave something across it, either an L stent or a MACE stopper, to just keep that skin dilated, and use the biggest catheter you can get across it. We like 14 French for our channels, especially if they have augmentation, so you can irrigate through this. So the only problem with the spiral Monty came out when we started looking at larger and larger series with longer follow-up. So this was just about 200 patients that had Monty channels, and we broke it down into if this was a standard Monty versus a classic kind of spiral Monty. The biggest thing we saw is that if it was an umbilical stoma and it was a spiral Monty, you had a much higher incidence, almost 17%, of needing an open revision to fix a problem. So that became the statistically significant difference for stomal site Historically, we thought it didn't matter where you put the stoma, but it was actually this problem where you used the Casal or spiral Monty, where you left the bladder down low and didn't hinge it up because it wouldn't reach, but you were using this long channel to kind of span that distance to get to the bladder. And this left a very large kind of inside the body, but extravesical portion that could angulate, create a diverticulum at the hiatus, or be difficult to catheterize over time. And it kind of didn't follow the classic Mitrofanoff principle of getting everything straight and supple to support that. So higher risk of subfascial, and subfascial means open abdominal kind of correction of these. So if we look at this, this is a stomal site didn't matter except the spiral Monty. Here's every other type of channel: appendix, Monty, spiral Monty to the right lower quadrant. The only one that mattered is this bottom right here, spiral Monty to the umbilicus. Much, much higher risk of needing additional surgery. So stomas, again, you can talk all day about the stomas. I personally like to conceal the mucosa as much as possible, except the patient that is very, very obese, where they tend to narrow them over time or have a difficult time finding them. The downside of obviously the mucosa being externalized is they make mucus, they stain their clothing. I think the umbilical stoma is the easiest one to hide. I use the CMOS technique, just make a U incision and bring it straight up. And this is the one I leave something across just to prevent it from narrowing. This child has two stomas here. So you can hide these even with just a little bit of a V flap. So we understand that it's a good channel. We got a 95, 98% chance of good success with them. 15, 20% chance of needing additional surgery over 10 to 15 years. So the question is, do the patients still use them over time? Are they useful to them? We looked at just shy of 600 channels with really pretty good follow-up. And again, that 11-year follow-up, and they were divided almost evenly between APVs and Montes. And based on follow-up, about 80% were still using them at 20 years. And again, remember, some of these patients kind of lost their bladder privilege, is what we call it, where we were actually diverting them or doing something else. But these were the original APVs. 80% were still using the 20 years, which is pretty good long-term success. It hadn't been written before. The same data there. Now, why did they stop using them? Interestingly, it wasn't really a mechanical problem. About 38% had something that we had to do. The channel got obliterated, or we just ran out of options to replace it. But actually, the larger number were not because of a mechanical reason. They were because of lack of compliance when the patient wasn't catheterizing themselves. So the number one cause here was catheterization by others. The second most common cause for disuse was actually the patients that weren't followed up in our transitional clinic. So they failed follow-up over long term, and they just stopped using it. So these patients all go to diversion. This is the type of diversion they ended up with. A lot of them were incontinent diversions, over half, just because the patient was failing. So we also looked at MACE. We've done about 600 MACEs now. So we wanted to know, do the patients actually use their Mitrofanoff channels, and do they use their MACE channels? And interestingly, it was almost the same, because remember, stool incontinence is really important. So at 20 years, about 85% or more were actually still using their MACEs to irrigate their bowel, because that was a good outcome. So if you look at the Mitrofanoff channels, here's what I would say is that we have great outcome on this. Sorry. I think the appendix is the best channel if they've got one. Again, we're gonna argue over this, whether it's better to use that for the MACE or the bladder. The bladder has such a higher risk of reoperation. I think if you're going to choose, use it for the bladder. You want to make it short, straight, and supple. They're going to do the best in both the short and long term. The revisions aren't going to stop as these patients age, the same as the bladder augmentation. If you do a Mitrofanoff, that patient's yours for 20 to 30 years. Stomal problem is the most common, independent of the stomal site, and then the bigger the channel, the better, especially if you've augmented them. So this is what your patients look like. This is the same patient. This patient was actually on national TV at one of the big TV shows, interviewed as a 25-year-old. This is her when she's about 8 years old. She had actually a cardiac operation. She's had her back closed. She has a BP shunt. All she cared about was wearing these poor-fitting panties in the left lower pane here. So I did an augmentation with Mitrofanoff, MACE, bladder neck sling. She bone dry. She came back. She was very active, actually, in helping other patients. So we did videos with her about How do you irrigate your bladder? How do you do it by yourself? How do you get everything set up to do that? And this is her. She actually went to Europe and studied for 6 months to be a fashion designer for people with disability. And this is her actually getting an award at our Riley Children's Foundation kind of fashion show as a young adult. So these kids all grow up. They still appreciate what we do for them. I think selection is probably the biggest thing, and actually asking the right question at the right age for what the patient might want and what they would benefit from. That's probably the key. Again, always end with a fishing picture. If you ever come across my wife at the ESPU meeting or some national meeting, please tell her I showed a picture of her catching a bigger fish than I did, because she'll appreciate that. But would be happy to entertain any questions. Thanks again for the opportunity to meet with you guys today. I hope this is helpful about how we've looked at this and inspires you to ask questions and do good work.
Thank you very much, Mark. Complete and amazing presentation. Thank you very much. We will waiting for questions. Maybe somebody. Okay, Francisca.
Hi, Mark. Hi, everyone.
Hi, Francis. How are you?
I'm fine, and I'm really like, I really want to thank you because you are like a live legend of the urology, and I feel very lucky to hear from you all the huge experience that you have and all the lessons that you have learned and how you can always be so kind and humble to transmit all that information to younger people. So thank you, Mark. That's the first thing.
Thank you. I appreciate that.
The second thing that I want to tell you is, do you have any experience doing split appendix for Monty and May's procedure? Or I mean for Mitrofanov and May's procedure? Because actually I tend to do that every time that is possible if you have a longer appendix. And what I found is that actually you don't need a big channel to live for the May's procedure. With 1-2 centimeters, it's enough to do a good maze. Usually I will leave it with a stopper because it tends to close. But with good irrigation, there is no problem really with leakage. It's very, very rare to have that problem. Usually when the patient leaks is because they are not doing the proper cleaning of the bowel. So is that your opinion?
Yeah, and I agree with you completely, Francesca. If you look at the literature, there's some reports that actually have less than what I would consider the usual outcome that you probably experienced and that we've experienced. We looked at about 70 kids that had that. Now, if you go back, it was real popular to staple to try to extend the small stump of appendix into the cecum. And I made some really big mistakes early on using a dividing stapler. Kurt Sheldon's technique, where if you have just a really tiny stump that may not be enough and you're worried about incontinence, you can actually staple it with a non-dividing stapler and just oversew the holes and then plicate that extension inside the cecum and bring that up. So I agree, you need only a small amount. If you're worried about incontinence or leakage, you can staple it to extend it in. And I think in those patients that we've done that, their outcomes have been equivalent. I agree with you. So I think the appendix is the best for both those channels. And that's why I think we would both agree that's best to try to split it and use it the best you can, because anything else you do for the MACE, if you just put a cecostomy tube in, a lot of them will leak. The patients don't like them. They get a lot of fleshy tissue around them. But if you can give them a stoma like that, I think their satisfaction, their outcome is equivalent for a split and non-split appendix for both. So thanks for bringing that up. I 100% agree with you.
Thank you. Any other question? Okay. Dear Mark, I think you don't have we don't have more questions than this because your presentation was so complete. Thank you. And we appreciate your presentation and you be kind with us to be with us in this moment. Okay. Thank you very much. And maybe you will be with us here in Bolivia as soon as possible.
I would love to come visit you guys anytime and just share our experiences in person. I think that's really important for young and old urologists. I'll be 65 this year and I'm still learning from everyone. So would enjoy that opportunity to come see what you guys are doing.
Thank you. And thank you to everybody to be with us. Bye-bye. Bye, Mark. Thank you.
Bye-bye. See you all in Vienna, I hope.
Muy bien. Gracias a todos. Los que se han quedado, les paso la información. Vamos a tener como invitado el próximo mes al doctor Anthony Caldamone y al doctor Si Yang de Rhode Island. Hasta pronto.